The next section covers thyroid hormone regulation. This slide shows thyroid hormone feedback mechanisms using, again, the HPT axis as the example. So from the hypothalamus is released TRH, or thyroid releasing hormone, which then stimulates the pituitary to release TSH, thyroid stimulating hormone, which then in turn works on the thyroid to release the thyroid hormones T3 and T4. And T3 and T4 feed back in a classical negative feedback back to the pituitary and the hypothalamus. Each of these portions are regulated by components that are both stimulatory and inhibitory. So for example, hypothalamus TRH release is inhibited by alpha blockers and stimulated by alpha agonists. Likewise, TSH from the pituitary is stimulated by estrogen or TRH, whereas inhibited by somatostatin, dopamine, glucocorticoids, or even by chronic illness. And finally, thyroid hormone release is stimulated by TSH or a TSH receptor stimulating antibody or iodine, and inhibited by iodine or lithium, and also by TSH receptor blocking antibodies. So it's important to know the basic axis, which is the HPT axis and its regulation, and in terms of what gets stimulated and what gets inhibited as well. In terms of how thyroid hormone itself is formed, it actually occurs inside the thyroid gland with 5 different steps. The first step is getting the iodine into the cell, called iodine trapping, and it is accomplished by using an iodine pump. Iodine is pumped into the follicular cells via a iodine sodium symporter, and once iodine gets in, by using the enzyme thyroid peroxidase or thyroperoxidase, the conversion of I- to I2 or iodide occurs. It's important to recognize this enzyme because it is the target of two important drugs, propylthiouracil and methimazole, both of which are used in the treatment of hyperthyroidism. Once iodide is formed, it needs to get organified. Organification is the incorporation of tyrosine into the protein thyroglobulin. And tyrosine residues of the thyroglobulin react with I2 to form the organic products MIT or DIT. And depending on whether an MIT and DIT molecule combine or 2 DITs combine, you get the thyroid hormone T3 or T4 respectively. That coupling reaction ultimately is the final reaction that produces the thyroid hormones. And it's important to recognize here that the main thyroid hormone is actually T4. That is the hormone that's actually formed inside the thyroid follicular cells. And then once T4 it gets out into the periphery, which is the target glands or the target tissues, so for example, the liver or the muscle or the bone, in that target gland is where the conversion of T4 to T3 happens. And the enzyme that performs that conversion is called 5' iodinase. And that is the second important enzyme in this pathway. Again, the first important one is thyroid peroxidase, and the second one is 5' iodinase. And 5' iodinase is also inhibited by PTU, but in addition to that, it is also inhibited by beta blockers. So this is the reason why when someone comes in with a thyroid storm, the drugs that is used to treat that condition is PTU and a beta blocker, because the conversion of the endogenous thyroid hormone is inhibited, but also the peripheral conversion is inhibited. In the next slide is essentially a reinforcing question to, again, just make sure that we understand how the important role of thyroid peroxidase is. So this question is asking, what is the mechanism of action of methimazole? Does it work by blockade of binding of the thyroxine to its receptor, decreased uptake of the iodine by the gland, inhibition of thyroid peroxidase activity, prevention of the proteolysis of thyroglobulin, or by stimulation of production of serum thyroid binding globulin? So the correct answer to this question is C, which is inhibition of thyroid peroxidase activity. Because again, remember, methimazole and PTU, both of them inhibit thyroid peroxidase activity, but it is only PTU that would inhibit the 5' iodinase activity in the periphery as well. The next slide highlights the three important thyroid function tests: TSH, free T4, and total T4. Of the three, TSH is by far the most sensitive indicator of the thyroid axis because it senses the status of the thyroid hormone levels itself. So for example, if the T4 level is low, then the physiologic response by negative feedback would be to increase TSH so that the T4 levels are then brought back to homeostatic levels and the normal levels are maintained. Therefore, TSH levels allow us to know if a change in the thyroid hormone is being driven by the pituitary or not. So for example, if the T4 is low and the TSH is also low, then you can pretty much guess that the underlying defect is likely in the pituitary as opposed to the thyroid, because classic negative feedback would indicate that if the T4 is low, then the TSH has to be high. And if that reciprocal relationship is not maintained, then you know that the problem is not in the thyroid, but in fact in the pituitary. And we'll cover all of this again in the form of questions and in a summary table at the end of this section. The second important thyroid function study is the free T4 level. So the free T4 level is, again, measures the free hormone as opposed to the bound hormone, and it's also an extremely sensitive measure, and is a good measure to check on because it is generally independent of any of the changes in thyroid binding proteins. Again, if you recall from the introductory section, we said that many of the hormones are binding to their binding partners, and one of the binding partners for thyroid hormone is thyroid binding globulin, which can get regulated by many things, including high estrogen states, such as that happens with pregnancy. And so sometimes when you have a high TBG level, you could get a false elevation of the T4 level, but if you measure the free hormone that is independent of these effects, then you get a true status of the thyroid status. So the last one is the total T4. Again, it is usually reflective of free T4 except in conditions where TBG levels are increased, again in the situation of pregnancy. So in this question, this is asking a question about the feedback mechanism that we just learned about. So this is a 50-year-old woman who has myalgias, nervousness, pounding heart, difficulty falling asleep, and decreased appetite, suggesting symptomology of likely hyperthyroidism. So she had a thyroidectomy, so her entire thyroid was removed 6 months ago, and as a result she is taking levothyroxine. Her heart rate is 120 beats per minute, blood pressure is 140/70, and her serum TSH levels are 0.1, which is low. So the question is, which of the following is the most appropriate therapy in her case? So again, remember that this question is saying that clinically this woman is looking like she has hyperthyroidism. Biochemical tests are showing that she likely also has hyperthyroidism because her TSH is low. And so the question is, what would you want to do in this case? Would we just give her some diazepam, fluoxetine, or imipramine, or verapamil because of the high heart rate, or decrease the dose of the levothyroxine, or increase the dose of levothyroxine? So the correct answer to this question is E, which is to decrease the dose of levothyroxine, because, as I said, she has no thyroid, so you're giving her exogenous thyroid in the form of levothyroxine, and likely, the dose is a little high because it's reflected by not only her clinical symptoms, but also by a low TSH, which is at 0.1. Normal TSH levels are between 0.5 and 4. And so the appropriate course of action here would be to decrease the dose of levothyroxine, which would then allow her TSH to normalize. The next slide talks about how thyroid hormone is actually metabolized. We talked a little bit about that in the previous couple of slides, where we said that T4 gets converted to T3, but T3 further gets degraded down to the inactive form T2 as well. So again, T4 gets converted to T3 in the periphery, in the target tissues like liver, brain, kidney, muscle, heart, and so on, by the enzyme 5' iodinase, which is the same as 5' deiodinase. And T3 in the periphery gets converted to the inactive form T2 by the enzyme 3' deiodinase. So anytime you have a decrease in peripheral conversion of T4 to T3, potentially it could lead to a situation where you would get a situation of a low thyroid status. And those situations could be anything that would involve caloric restriction, chronic illness, hepatic disease, and so on. And the pathophysiological consequence of such a decrease is something called euthyroid 6 syndrome. So again, in euthyroid 6 syndrome, patients usually have low active T3 because of the decreased conversion of T4 to T3, but they also can have an increase in reverse T3, where T4 gets converted instead of T3 to another inactive metabolite called reverse T3. The key is to be able to distinguish between this state, which is euthyroid 6 syndrome, versus a true hypothyroid state. And the test of choice in this case to distinguish between the two would be measuring TSH. And the reason for this is because, again, one, as I said before, TSH is indeed the most sensitive indicator of the thyroid status. So in ESS, the TSH levels are usually not increased. If anything, the TSH levels may be normal or maybe even slightly decreased. Because if you recall, we had mentioned that one of the inhibitory stimuli for TSH release is chronic illness. So chronic illness can suppress TSH as opposed to primary hypothyroidism, where TSH is by definition increased. So the TSH measurement will allow us to know whether a patient who has low T4 or a low T3 is having a low T3 because of true primary hypothyroidism or because of ESS. So looking at the pathophysiological consequences of thyroid hormone dysregulation, we can again divide them up as, too much thyroid leading to hyperthyroidism or too little thyroid hormone leading to hypothyroidism. So first let's cover hyperthyroidism. There are two main reasons for hyperthyroidism. The most common one is Graves' disease, and the second one is thyroiditis. And there are various types of thyroiditis which we'll touch upon in the next few slides. So the first one is Graves' disease. It is by far the most common cause of hyperthyroidism. Graves' disease is usually caused by autoimmune disease. Autoimmune because it is associated with a specific immunoglobulin called the thyroid-stimulating immunoglobulin, which binds to the TSH receptor and independently activates the TSH receptor. As shown in this slide, in a normal situation, it is TSH which should be binding to the TSH receptor. But in Graves' disease, thyroid-stimulating immunoglobulin instead binds to the TSH receptor and activates this receptor. As a result, you have greater production and release of T4, and increased T4 in turn suppresses the TSH. Eventually, increased T4 leads to all of the hypermetabolic symptoms of hyperthyroidism, such as tachycardia, anxiety, decrease in appetite, weight loss, and so on. And because this is an autoimmune disease, there's immune complexes that also get deposited in the back of the eye, the basement membrane of the eye, and as a result pushes the eyeball forward, resulting in a very classical pathognomonic finding for Graves' disease called exophthalmos or proptosis. It is important to note that in other forms of hyperthyroidism, you do not get this eye finding because this is again very specific to the autoimmune immune complex deposition in the back of the eye. How do we diagnose hyperthyroidism, especially because of Graves' disease? One of the common tests that is used, of course, besides the biochemical test, is a test called radioactive iodine uptake. And shown in this slide is in graphical form what an uptake looks like. So in the top portion of the slide is a representation of what is considered a normal thyroid uptake in green. So when you have somebody come in and take a dose of a radioactive iodine, usually it's iodine 125 or 131, the uptake is usually about 25%. Whereas someone who has Graves' disease will have an uptake, as shown in the bottom panel, of over 75%. And in fact, if you take a picture of the thyroid when this is happening, as shown in the lower right corner, you have a very diffuse butterfly-looking pattern. which is basically the outline of the entire thyroid gland. So Graves' disease is associated with a diffused increased uptake of radioactive iodine. And that is another pathognomonic finding of hyperthyroidism due to Graves' disease. Because again, remember, Graves' disease is autoimmune in origin. It's the whole gland that gets affected, and therefore, as a result of it, the whole gland takes up the excess iodine, which is manifested as this sort of butterfly pattern. So in this sense, the treatment of Graves' disease is simple in the sense that by using the radioactive iodine, you're not only making the diagnosis of Graves' disease, but in fact can use it as a treatment as well. So a small dose of iodine is first used to take the picture to see if there is increased uptake. And once you confirm diffuse increased uptake, then you can dose the patient with a larger dose of the radioactive iodine, which then very specifically kills off all of the thyroid follicular cells, which then can ultimately decrease thyroid hormone production and, in a sense, cure thyroid hyperthyroidism. Some people may not prefer radioactive iodine, and in those situations, the drugs that we talked about before, PTU and methimazole, will be very useful. And in really complicated cases where people are not tolerant of any of the drugs or cannot be candidates for radioactive iodine, surgery can be used as an option. However, it is not a very common option, especially because the first two are fairly effective. And again, it's important to note here that radioactive iodine is both diagnostic and therapeutic for Graves' disease. So let's quickly test our knowledge about the pathophysiology of Graves'. This question presents a 42-year-old woman reporting fatigability, nervousness, irritability, heat intolerance, which again clearly tells you that she has symptoms of hyperthyroidism. She has diffuse goiter, exophthalmos, which is again proptosis, a very specific sign telling you that this woman has hyperthyroidism specifically because of Graves' disease. And they want to know the circulating antibodies to which of the following are most likely to be found. So basically, in the stem of the question, you already know what this diagnosis is. So the answer should be E, which is the antibody against the TSH receptor. So let's move on to the second most common cause of hyperthyroidism, which is thyroiditis. So as shown in this slide, there are several causes of thyroiditis, and the most common being something called postpartum thyroiditis, which is, as the name suggests, a situation that happens in the setting or shortly after childbirth. There are other causes which can include acute thyroiditis, which can be infectious, and most of the time it's induced by a viral infection. There is something called subacute thyroiditis, granulomatous thyroiditis, Rydell's thyroiditis, or finally chronic lymphocytic thyroiditis, or commonly called Hashimoto's disease. So in all cases of thyroiditis, at least in the initial phases, there is the possibility that patients could manifest symptoms of hyperthyroidism. However, as you will notice later, thyroiditis generally progresses and ultimately progresses to hypothyroidism, as is the classic case seen with chronic lymphocytic or Hashimoto's thyroiditis. But regardless, the workup for hyperthyroidism is presented in the right panel of this slide. So if people present to you with symptoms of hyperthyroidism, the first thing that you would obviously get is biochemical testing. So you would want to see this reciprocal change where you have a suppression of the TSH and an increase in T4. That tells you that at least this patient has primary hyperthyroidism. Then your job would be to figure out whether this hyperthyroidism is because of thyroiditis or is it because of Graves' disease. And the test of choice in that situation would be to use radioactive iodine uptake. And as I told you before, radioactive iodine uptake is diffusely increased in situations where the hyperthyroidism is because of Graves' disease. Whereas people who have thyroiditis will actually have a suppressed uptake or a completely decreased uptake. And in that situation, the diagnosis would be thyroiditis. If the biochemical testing obviously shows suppressed T4 and an increase in TSH, that in fact tells you the diagnosis is not hyperthyroidism, but in fact hypothyroidism. And in those situations, you don't really need to do anything further but then to treat the hypothyroidism, and the most common cause for that would be Hashimoto's disease, as we'll cover in the next slide. So a quick question to again reiterate some concepts. This is a 38-year-old woman who has a gradual development of a goiter. In this situation, the serum free T4 is in the reference range, but the serum TSH concentration is slightly increased. And this question goes on to tell you that the serum contains anti-peroxidase antibodies, but no TSI antibodies. So what is the diagnosis in this case? So clearly, this woman has no TSI antibodies, which likely means that this woman doesn't have Graves' disease. And you know that she doesn't have Graves' disease also because her TSH is actually increased, not decreased. So this is a case where the patient actually has something called subclinical hypothyroidism, because her free T4 is actually normal, but her TSH is actually increased, and she currently is not manifesting any obvious symptoms of hypothyroidism, but eventually will go on to develop that. So the most likely diagnosis in this case is Hashimoto's thyroiditis, which is the most common cause of hypothyroidism, as shown in this slide. So again, main cause of hypothyroidism is Hashimoto's, or it could be because of an acquired situation like thyroidectomy or because of radioactive iodine ablation. Symptoms are pretty straightforward in the sense that in hypothyroidism, most things are slowed down. So they're slowing down of bodily processes, which then lead to lethargy, cold intolerance, constipation, weight gain, or mood changes. Treatment is essentially the replacement of the hormone. So levothyroxine is the treatment of choice. This slide summarizes for you the major concepts regarding thyroid function studies and how to interpret them and what the next steps are. So the first thing that you want to look for is get the TSH and then the free T4. And then look at the pattern to see what the diagnosis is and try to match that with the clinical picture. So the clinical picture suggests that someone is looking like they're hyperthyroid, meaning that they have increased anxiety, tachycardia, weight loss, all of those symptoms. You want to look at the TSH and free T4. If there is a reciprocal relationship, meaning that the TSH is suppressed and the free T4 is increased, then the diagnosis is primary hyperthyroidism, again, most likely because of Graves', and you want to work up the hyperthyroidism based on the algorithm that I had presented before, which is you would do radioactive iodine uptake, and if it is diffusely increased, the diagnosis is Graves'. You can confirm that by measuring TSI. If the uptake is decreased, then likely the diagnosis is thyroiditis, and then you proceed accordingly. If, on the other hand, the TSH is also increased, along with the free T4, which is also increased, then the diagnosis is secondary hyperthyroidism, meaning that the cause for the hyperthyroidism is not in the thyroid, but in the pituitary. In that situation, the most likely cause for that would be a pituitary tumor, especially due to a TSHoma. And in that case, the next step would be to get a pituitary MRI. In the converse situation, when you have a presentation where the patient is presenting with symptoms that you think is consistent with hypothyroidism, meaning slowing down of bodily processes like constipation, weight gain, lethargy, and so on, you want to get your biochemical test first, which would indicate to you whether the patient has primary or secondary hypothyroidism. So again, look for that reciprocal relationship. If the TSH is increased but the free T4 is suppressed, then the diagnosis is primary hypothyroidism. Most common cause is Hashimoto's thyroiditis, and you can also confirm that by measuring anti-peroxidase antibodies. If you don't see the reciprocal relationship with the hypothyroidism, meaning that you get a low T4 but also a low TSH, then the diagnosis is secondary hypothyroidism. The problem lies in the pituitary and not in the thyroid. And then again, the next step in that situation would be to get a pituitary MRI. So let's switch gears now to talk about, in the last section of the thyroid, the changes that occur with the thyroid in the setting of pregnancy. Because this is one of those topics that does get tested often because, first of all, thyroid disease is fairly common, and there's unique challenges to deal with thyroid disease in pregnancy. So some of the major alterations that happen in the thyroid system during pregnancy include three things. The first one is an increase in the serum TBG. As I mentioned to you earlier, thyroid binding globulin is the binding partner for thyroid hormone, and this protein gets increased dramatically in situations where estrogen is increased, and that is a situation that happens during pregnancy. Total T4, therefore, as a result of that, increases as well, as greater than 99% of the T4 is bound to TBG. However, the free hormone, that is the hormone that is not bound to the protein, is in fact unchanged. And therefore, in these situations, it becomes really important to just measure the free hormone levels and not get a total T4 level. The second thing that happens in pregnancy is an increase in demand for iodine. So, because of either increased demand or because of increased clearance of the iodine as a result of an increase in GFR, there is the need to maintain normal iodine levels. The thyroid gland can increase in size during pregnancy, especially in iodine deficient areas around the world. And the third important thing that happens is the stimulation of the thyroid gland by HCG. Again, if you recall, HCG, like TSH, is a glycoprotein and has a very similar structure to the TSH itself, and therefore can weakly turn on the thyroid because it can bind and transduce signaling from the TSH receptor. So high circulating HCG levels in the first trimester may result in slightly low TSH, as shown in the graph on the right. In blue, you see that the TSH levels have a transient suppression in the first trimester, but they pick up back again in the second and the third trimester. So the take-home point here is that in the first trimester, the only hormone that is a true valid measure of the thyroid status is in fact just the free T4. So because again, total T4 is not a valid measure because of the increase in TBG, so that gives you a falsely high total T4. And in the first trimester specifically, if you measure TSH, you'll get a falsely low suppression, and as a result of this increase in HCG. So the only true measure in the first trimester would be to just get the free T4. Summarizes all of the tests that we should get, and as well as the changes that happen as a result of pregnancy. Overall, it's important to recognize that laboratory tests of thyroid function should be interpreted with caution. So again, very specifically in the first trimester, the only thing that would be a true measure is the free T4. TSH will be slightly decreased, total T4 will be increased again because of an increase in TBG. In the second and the third trimester, TSH levels come back to the normal range, and free T4 should be in the normal range, but the total T4 continues to remain high because of an increase in TBG. So again, I would like to emphasize that point that in the first trimester, the only hormone that would be a true measure of the thyroid status would be free T4. This question is dealing with neonatal thyroiditis or neonatal thyroid disease. So this is a neonate with swelling of the neck, which is a goiter, has decreased free T4 and an increase in the TSH. Which of the following agents that were chronically ingested by the mom during the pregnancy is the most likely cause of these findings? So first of all, this neonate has a goiter and has hypothyroidism because of a decrease in T4 and an increase in TSH. And the reason for this situation is because the mother ingested a lot of PTU. So if you remember, PTU is the drug that actually inhibits thyroid synthesis. But PTU can also cross the placenta. So a lot of PTU, if the mom has taken, will cross the placenta and then affect the fetal thyroid axis as well, suppressing the fetal thyroid axis system. And the rest of the choices here really do not produce this specific constellation of findings. So again, just to emphasize, thyroid hormone and fetal development. So in the first trimester, the baby is completely dependent on the mother for the production of thyroid hormone. But by the end of the first trimester, the fetal thyroid itself starts to mature, and the fetal thyroid axis system then takes over and produces thyroid hormone on its own. It's important to recognize what happens to the thyroid system, both from the impact on the mom as well as the impact on the baby during pregnancy. So again, because of the fact that in pregnancy there is an increased demand for iodine, it's really important to make sure that we screen for women who have subclinical hypothyroidism. Because in women with subclinical hypothyroidism, meaning they don't have clinical symptoms and they have a normal free T4, but they have a slightly high TSH, the extra demands of pregnancy in this situation can actually precipitate clinical disease. And overt maternal hypothyroidism is essentially has significant consequences for the mom, such as anemia, myopathy, preeclampsia, postpartum hemorrhage, and so on. So to avoid these complications to the mom, it's very important to make sure that we screen and treat subclinical hypothyroidism in pregnancy. Conversely, on the baby, thyroid hormone is really critical for the maturation and the development of the brain. And in children who are born with congenital hypothyroidism, that is no thyroid function at birth, they can have severe developmental abnormalities and severe developmental delays leading to mental retardation and several other complications at birth. And if it's a significant cause and where the baby remains untreated, it can lead to a permanently mentally and growth retarded state called cretinism. So again, the take-home message is that for both the mom and the baby, it's very important to monitor and screen for the thyroid axis during pregnancy and to ensure that the thyroid hormone levels are in fact maintained in the normal range. So this concludes the section on thyroid disease and thyroid hormone regulation. The take-home points again are to recognize that the thyroid axis is regulated from the hypothalamus and from the pituitary with classical negative feedback. The most common cause of hyperthyroidism is Graves' disease. The most common cause of hypothyroidism is Hashimoto's. And it's very important to recognize that there are significant changes that are happening in pregnancy. And as a result, it is very important to choose the right biochemical tests during pregnancy. And the test of choice, specifically the first trimester, would be just free T4. And during pregnancy, total T4 really has no place in terms of a diagnostic modality because of the increase in TBG. In the next section, we will cover the regulation of the adrenal cortex. So this concludes the section on